Hello and good evening, good morning, good afternoon, wherever you are in Africa and beyond. This is Africa's Health Pulse, and I am your host today for the first time, Odhiambo Brian Otieno. Many of you have seen me elsewhere, and if you haven't, welcome. But if you've seen me elsewhere, also know that I serve as the CEO of the Chronic Disease Society of Africa, which is the executive production team of this very good podcast to you. And the guest that is joining me today is the chairperson of the Chronic Disease Society of Africa. What we wish to discuss today is something very interesting that sits at the center or at the core of your healthcare. Every day when you wake up going to work or just doing your things, one of the things that could be bypassing you is, what does my health data look like? Have you ever wondered where your health data is, how it is used, and especially how it is stored and used to improve the outcomes and also used to predict possibly the policy formulations across the continent that will come back and affect you and your children and your loved one as a person. So, of course, it's a privilege to have Faith Okwesa-Okwayo, who is an actuarial scientist, having studied operations research. Very good. Faith here is, as I've said before, the chairperson of the Chronic Disease Society of Africa, but also she's the director in charge of partnerships at Afya Analytics, which is a data aggregation company that has a global scale of understanding the data health sets in Africa and beyond. Karibu sana Faith. Today we are going to discuss the question of where is our data going and how is it helping us? The question of data. Karibu. Give us an overview.
That was quite an introduction. I think you should host me more often.
I have to try.
You remind me of why we're here.
Oh yeah?
Yes.
All right. So give us an overview basically. What do you... Okay, this is going to be an interesting interview. Yeah, and I'll tell you why someday, maybe not today. Yeah, so give us an overview. How does our health data in Africa look like?
Even before I come there,
Yeah.
I want to tell you why Chronic Disease Society of Africa. Many people have asked me, what inspired you to start Chronic Disease Society of Africa?
Right.
Let me just give you a small brief. 60% of people who are living with diabetes are highly likely going to have kidney failure.
60%
60%
of people living with diabetes are highly likely to have chronic
kidney failure.
Why will that be so?
Because diabetes is a risk factor and is a high indicator of kidney failure, because it's a multimorbid, it's rather a comorbid of diabetes. So most of the kidney failure, and very soon we are going to sit with Dr. Soki, a nephrologist.
Yeah. I remember her.
One of the few kidney transplant experts. And she's going to emphasize on that topic. But why am I highlighting that? Because initially I had a patient who happened to be my father, who was suffering from diabetes, but ended up dying from cancer, meaning the multimorbids or comorbidities around his disease were not given priority, because primarily from his diagnosis of diabetes, that's where the physician leaned. So there's a gap in longitudinal patient tracing, just to ensure that this patient is getting quality care.
So let's break it down for our audience so that they don't get lost in the medical jargon. When you talk about comorbidities, what do we mean?
A disease that begets another disease.
So a disease that attracts the other.
Yes.
So like, for example, when you have
obesity will attract 18 other chronic diseases.
Okay. So obesity provides the landing pad for 18 other diseases. So once you have obesity, then you're open.
Yeah. To have fatty liver, fatty heart, gut, gastrointestinal issues. You're gonna have kidney issues, hypertension, diabetes. So like obesity is a precursor and an indicator, even though obesity itself, WHO recently has put in the category of chronic illnesses.
Obesity in Africa is almost something that is looked at as normal, in fact beautiful. If you show up at a place, at a workplace, and you look like you are slim like myself, I don't know if I'm very slim, but if you look like myself, they say you are still suffering a little bit. But if you have a big tummy and you look big, they say that's the African shape. Is that right?
Those are myths. because I think predominantly the African shape for the woman is bottom heavy. So what we really want to fight is the central obesity.
Okay, central obesity, you mean a big stomach?
Anything, as Dr. Gikonyo says, when you open the door, when your stomach is leading, the stomach enters the room before you do, then you know you're in the risk category. Yes, but I'm trying to circle back to just come to your data question.
Okay.
So chronic diseases are a silent killer. And they're killing us more than we know. And some people even die in their sleep, like we always say. They have myocardial infarction without ever knowing they were sick. So we came up with Chronic Disease Society to be able to, number one, amplify the patient's representation and voices in policy-making boardrooms by harnessing their experiences, their lived experiences, and representing that in a corporate way. Secondly, to be able to improve early detection for these diseases, because the biggest burden in Africa for chronic diseases is late diagnosis, underdiagnosis, and misdiagnosis.
So now, if you allow me, just on that very point, there's a very interesting question about the African when they're going to seek for health services. I believe that's what we call health-seeking behavior. One time we were with you in Siaya, in Kenya, when we went for a medical camp. And I remember going to mobilize people to come to the medical camp. And when I went to the market in Siaya, I did ask people to join us, but women refused.
That was interesting.
It was very interesting. I would like you to highlight, why is it that, because you're saying we should have early diagnosis, but early diagnosis is absolutely voluntary. How do we ensure that we have early diagnosis to capture interesting data points? For example, when we know that this number of people could be suffering from or are pre-exposed to this kind of disease, so we can plan. How do we ensure that Africans can actually go to hospital and get checked early? How do we ensure that?
I think that's really right in the seat you sit in the purview of politics, because for us to be able to ensure that people are eager to have early detection is to improve quality of care and to improve insurance representation or equity, to improve access to care, and to have proper referral systems that work for the people, reduce the cost of illness. So all this whole constellation of barriers are the reason why people hesitate. So I remember that particular day, some people are like, me, I already have HIV, I'm happy, I don't want to find out I have diabetes because that will kill me further. I'd rather die, like I'd rather have the, should I say, the illusion of not knowing? Like, I'd rather not know than know I have diabetes. I'd rather not know than know I have cancer, because whatever will kill me is the stress. Why were people saying that? I think it's because of the cost of care, the cost of illness. Once someone has cancer, they are defeated mentally, because they're like, I'm a breadwinner. How am I going to present to my children? Who will rely on me? Because I cannot even afford primary care. How will I afford this chronic illness? I
cannot afford to buy drugs, medicine. Yeah. So how will I afford going to the hospital? So then how do we, because when we're talking about improving insurance cover, etc., it sounds to me like 30 years, 50 years to come in Africa.
Not when Chronic Disease Society is trying to fight for the people. Okay. Not when now there are people who are trying to use data to improve outcomes. Not when there's enough evidence that can be synthesized to find what else is possible in the healthcare access systems. Collaboration and partnerships are a key element in trying to maybe alleviate suffering. The government, and I don't want to speak much and be political about the government, but the government has the power to improve access to care through private and public partnerships.
Should it look like, well, I do get your point of saying that we need to have government in improving that. But should we have, like, because I'm just trying to imagine from the political side where I could be sitting, if we, in every ward almost in this country, ward is a political representation in Kenya, the smallest unit of political representation. If we go to every ward, should it be compulsory that every month or every year, at least there is one medical checkup that is enforced?
Yeah, we
Could that work?
We must work on that as a policy issue.
That people must get checked. It becomes a question of must.
Yes.
But then the question is, what does that mean to the government in terms of costs?
Of course, the government will be afraid of that initiative, and the private insurance will also be. Did you know something interesting? When I was at the health roundtable with WHO and CDC, we realized, or rather there was data and evidence that only 10% of Africa is insured.
Only 10%?
90% of Africans are not under any insurance schemes.
Wow.
So I don't know if it's the social health-seeking behavior where the Africans are insurance averse, or there's some level of lack of transparency in the insurance systems where people don't even trust that if they pay for this insurance, they'll get the right returns that they deserve. Because you find even people who've been paying insurance for all their life, immediately they get sick, the insurance gives them capitation, so gives them
limits their expenditure.
Yes.
Yeah.
And they're like, if you have cancer, if you have arthritis, you cannot go
can only
beyond
spend
$500,000.
Yeah.
You cannot go, and $500,000 is just one vial of their drug, you know. So a friend of mine was telling me, if you want to have insurance, invest in Bupa, invest in Cigna. Please.
What are those?
Those are international insurances that at least will guarantee you can get treated well anywhere.
Say that again so that our audience remembers. Please highlight. It is important because that is, I mean, it's something that could save them.
I speak to many patients.
Yeah.
My passion is to make sure that patients are being well controlled, especially patients who are living with a disease for the rest of their life, that they can be able to access the treatment they deserve, they can be able to access specialized care, and they can be able to access quality drugs that are not counterfeit, that are not compromised, that are not inefficient. So in this interacting with patients, I get a lot of feedback on what is working, what is not working. And one of them who survived multiple diseases and has been living with 2 or 3 diseases told me that insurance does not serve them at all.
The local insurances in their country?
Zero.
Okay.
They told me they were very loyal clients, paying insurance. And you know, sometimes people or parents are like, let me just pay for my kids because at least they'll have optical care once a year checkup, they'll have dental access once or twice a year checkup. But they do not rely on it when they get sick. Like this insurance, immediately you get sick is when you meet the reality.
So let's just roll up a little bit, or roll back a little bit. When you were talking about the question of people being able to get quality care, one of the questions that is coming up is, of course, validly the question of insurance. But as I was just talking about that, I'm wondering, health is being treated as a business largely. Are you saying health shouldn't be a business because insurances are businesses and they are collecting to go and make profits? Shouldn't that be the case? Or what is, do you call it Bupa? Bupa. What is Bupa and the other
Cigna.
And Cigna doing differently that the local insurances are not doing? Are they looking at health as a right, not as a business, and the others are looking at health as a business and not as a right?
I think there needs to be higher surveillance and vigilance from the regulatory authorities that then ensure that there's fairness in practice and best practices and integrity, even as this service provision. The insurance market has largely, of course, relied on I don't want to say it's gamble.
But that is what it sounds like. That is what it sounds like. Insurance sounds like gamble, where you put money in a risk pool, and at the end of the year, when that money is not utilized, whoever owns the insurance firm takes the money.
They are largely depending on you not to utilize that money.
Yes.
So now
it's gambling with people's lives.
More on the patients,
yeah,
because they pay, but the insurance companies are not expecting them to get sick.
All right.
The worst they've budgeted for is an accident, right, or maternity.
So first aid.
Yeah. But when it comes to proper care, when it comes to a chronic illness, unfortunately, it's really, the stories I have, the data I have is really, really bad. And even the more people who take advantage of these insurances, beyond the insurance company themselves, are hospitals or clinics where that's why claims don't go through quickly, because there's a lot of
due diligence to be done by the insurance firms?
Because there's overpricing, there's inflation, and if you understand well, it's because also there's delays in payment. And I don't want even to capture insurance per se. My point is our patients are afraid to seek healthcare because they will not be able to afford this cost of care. So they'd rather live with the deception of not being sick rather than find out they're sick. That's why we have this high level of late diagnosis. Another factor would be for the men especially. And trust me, there are around 68 to 75 urologists in Kenya. And I've spoken to a good percentage of them, and they've said prostate cancer and male cancers mostly, colon, which predominantly affects men, and prostate, is the highest late diagnosis cancer ever. Because also men, now beyond even the females, male delay further to seek healthcare. Men do not seek healthcare until it's very critical, until it's too late. So we need to improve our education and our awareness campaigns so that men feel comfortable to go to a urologist and find out why is this happening to my body. So because these cancers are treatable if you get them at stage 1, stage 2. But you know when
or even stage 0.
Yes. So we are trying to step in that gap and tell people it's okay to seek care, while also fighting for their representation.
But Faith, the question that is coming out, even from by your own admission, is that we have a challenge in terms of affordability. So when we're looking at insurance and saying people need to have better insurance covers so that they can improve the health-seeking behavior, etc., the first question becomes, if, for example, you go to, let's say, Accra, Ghana, or you go to Kampala, Uganda, or you go to South Africa, wherever. Even Egypt. The meeting we had with with the ambassador of Egypt, Kenya. Yeah.
The drugs are very affordable there. Why? Because the pricing is fair, the margins are controlled. In Kenya, the margins are not controlled.
That is one bit. Well, the question I was asking you was this. If you look at across Africa, and any African who is watching this knows this very well, that most Africans would ask you, would they rather buy breakfast than seek health services? Because buying breakfast assures them of survival. Going to hospital destabilizes their security, because they're like, if I go to hospital and as you're saying, I'm going to find out I'm sick, it's hectic. And then how am I going to treat myself? So how do we first even sort the question of affordability from your standpoint as an actuarist? What has happened in contrast it to best practices in the world? Do we have countries where question of affordability is not an issue, so that it becomes the first point where people know that if I go to a hospital and seek or be diagnosed, I'm saying that I'll be taken care of?
Like Canada and Thailand.
What did they do differently from Africa?
Like you said, they made health a public policy issue. Health is a public concern. Health is no longer the preserve of the private market. Because once you leave health in the private market, of course, the profits and the margins are the ones that technically increase the cost of care.
Yeah.
But if the government subsidizes most of these costs, and primarily because healthcare is a right, it's a human right. Actually, it's written all over WHO, in the UN charters. Healthcare access is a human right. Primary healthcare access more so. But in Kenya, even primary healthcare access comes at a very heavy cost. And insurance is a scam. Be it whichever insurance you name it, you are not guaranteed that you'll have proper coverage.
Insurances are a scam.
Yeah. In the current market. Unless something is done about it at policy level.
Largely in Africa, insurances are gambling.
That's why we have 90% of an insured market. There's a reason why. So we need them to see either politically or using health economics or better planning, how we can really take care of this issue.
Let me put a question to you. You studied the global health economics properly. Would you say so?
There's so much more to learn.
There's so much more, of course. Is there a particular country in the world where health is free? The public does not pay a cent when they go to seek for healthcare services?
I think Canada is fair. I don't know. No countries coming to my mind right now because I didn't even prepare to talk about the economics of health.
Okay.
But it's possible and it can be done.
How is that possible? How can, for example, Uganda, how can, for example, Namibia have a clean slate of healthcare access where every citizen does not worry about the cost? It is ensured, it is covered by the government that for as long as you are born in that country, you are able to gain access to healthcare for free for the entirety of your life.
You have the answer to that.
How? I don't have it. I don't have it. That's why I'm asking.
First of all, you need to get to that parliament. It's different.
That's when I get there.
And I don't want to digress conversation about chronic health and early detection and data to a public health issue, because the power lies in that parliament, the power lies with the executive, and what can be done.
What do you think? Of course I know. What would you share with our audience?
In Africa, Abuja Declaration is never been honored by many countries.
What did you talk about that concerns?
10% of the budget should go towards health.
And that means health should therefore be free.
Ideally, health should be free.
Okay.
Health should be free. Then people will even have better health-seeking behaviors because
ideally health should be free. Absolutely, people should not pay anything. But then in our next conversation, I would like us to discuss a little bit more on the health economics. But let's come back to the topic, which is the question of health data in Africa. It is said that most of clinicians, nurses in charge, doctors, do not make proper diagnosis based on data. They make it based on feelings and whatever else. Can you tell us more about that?
The bulk of healthcare records in Africa are paper records. The bulk. Even a librarian cannot be able to exhaust a report from physical books. They must collect it and table it and then use certain formulas to be able to come up with a report. So if the bulk of your healthcare history and data is in paper records, you're not going to be able to make net decisions about the sick, about the patients, about the hospitals, and about how to run healthcare. So the first issue with African healthcare data is lack of it. The bulk of it lie in paper records. Second is fragmentation of it. You find there are many disparate healthcare systems within the same setting that cannot be interoperable and make good decisions based on that. The third is, of course, the paper record makes it very invisible, so many decisions are blind. And
blind decisions. Yes. What would that mean to my audience?
Blind decision means decisions that are made without proper evidence generation. And remember, healthcare is the most compulsive sector where decisions must be made based on evidence.
So if I hear you correctly, are you saying that the evidence that is used to make decisions should also be empirical? Like you cannot decide about my health situation today without understanding my health history.
Yes.
And most and most African nations do not have health history of an individual.
I don't think there's even any, unless someone is 12 or 18 years old, I don't think there's any single record in Africa that's end to end.
Like from when I was born to now, I cannot find the accumulation of my health data in one system in Africa.
Because where you're born, I'm so sure they use a paper record.
I think so. It was in the 90s.
And your birth record is sitting in a file collecting dust if it's not already extinct by now.
That if the file gets burnt, those records are done away with.
Yes. Maybe and then even mortality data, the reason why someone is dead, is also not captured in proper systems. So when a nurse is recording the experience of you at the end of the shift, or how many people have given birth, how many people have died, how many people have been in this ward admitted, based on a hunch or their memory at the end of a very busy shift, and they are trying to hurry to go home. How will that be accurate? Right? And this is the data that's collected at national level. So there's a lot to be done there in terms of even data structuring, data capturing, complete data capturing, because also you find data capturing is fragmented. They capture bits of it and not all of it.
Afya Analytics, where you are director of partnerships, must be talking about ensuring that we don't have siloed data.
Yeah.
How are you structuring it to help solve this issue? Because I'm getting frightened by just the imagination that I could be having an underlying disease that is captured in very many different hospitals, but the particular doctor that I'm seeing at this particular time is not aware of that reality, and he or she recommends a different set of diagnosis, whereas maybe a diagnosis is already reached, and I don't know because I don't know how to speak English, perhaps, all right? But that data is captured elsewhere. But this doctor makes a whole new set of decisions, including the drugs that they're giving me, without understanding that maybe I am already resistant to this particular drug. What are we looking at? What are we dealing with?
Or even worse, to support
Yeah.
your case,
Yeah.
if the doctor you're dealing with dies or is transferred, then you have to meet a new doctor. You have to start all over again, explaining your history and trying to start all over again to get treatment and to get better follow-ups.
Are you having a suggestion on how this can be sorted?
So Afya Analytics, as
Yeah.
you asked, sits on a backbone of a very strong HMIS system. So it deploys healthcare management information system at scale. And this healthcare management information system is state-of-art, is the latest, is the best I've ever seen, experienced, and it's capturing this on cloud, so your data will never be lost. And then it captures every single step of the workflow of a hospital, from the time you enter to registration and you triage and you go for consultation. And even at the consultation, there's speech to text, where whatever you're saying is captured by AI and then it's translated into the system. So the doctor doesn't have to worry about capturing everything you're saying. Then it supports in clinical decision support. And then when you go to the pharmacy, it captures all your history and the drugs you've been using, everything. If you're counter indicating in anything, it captures all that. It also captures the price, your competitiveness, and make sure that you're taken care of.
It's concerning that.
And then that history is harnesses at scale, and then analysis are provided, and you're able to be safe for longevity.
Let me ask two questions here. One, how is this data system that Afya Analytics has developed able to go back to when I was born and capture that history, and how are you planning to do that? Number two, how is this even enforceable? Because therefore it means that health must be an end-to-end ecosystem, where from the diagnostic point or the triage to the pharmacy, all these people can access this single point of data. How is it going to be deployable? Because it borders almost, if not so, it borders questions of data privacy, data integrity, data what? I mean, there's a lot of concerns around data in terms of how it is handled. People are not very willing to share.
Concern or fear.
Yeah, they're concerns.
There are fears,
Yeah.
and fear comes from ignorance.
Oh, okay.
Yeah, because
Fear comes from ignorance.
Yes, allow me, because
Okay.
you only fear what you don't know.
All right, okay.
You only fear things you cannot predict perfectly, the outcomes, and when your expectations are not being managed, then you go into the fear space. So, of course, for anyone to do anything, they must be compliant. When it comes to data, there's a compliance body, or DPC. Of course, there's international
What's the DPC?
Office of the Data Protection Commissioner.
That is for which country?
Kenya.
How about the other countries in Africa? Do they have it?
Yes, I think the regulatory system is a bit weak, but in
Okay.
Kenya we are strengthened, and of course our DPC regulations are informed by international regulations, HIPAA laws, and GDPR from Europe. HIPAA is American. So before you are able to be in any market, you must be licensed. So for Afya Analytics, we are well licensed. We are licensed by the ODPC. We are licensed by GDPR. We are licensed for data controlling and data use, controlling and providing. Like, we are data providers and data controllers. We are also registered under DHA for digital health data.
DHA is what?
Digital Health Agency.
Okay, that's a regulatory body in Africa as well.
No, that's Kenya.
In Kenya, okay.
DHA it's a very complicated thing. It's the SHA consortium, the TBAB, and the ones who are trying to improve digital access in Kenya. So they also somehow have a say in how you access and the maturity of your systems and how you deploy them. You must be under certain regulatory obligations. So to your question of your history being harnessed, if you are lucky, and because Afya Analytics is going into historical data, just trying to turn those paper records into digital records to make sense from them across over 3,000 hospitals, and doing that at a local ownership level, so from facility to facility, and just turning those paper records to digital records. Then your history can be preserved if it's still within the hospital.
This looked like it is almost impossible for me to go back, or for me to share with the Ministry of Health or yourselves all the hospitals I've visited, because I know them all. Are you able to go back to those hospitals and retrieve my record and keep it under one unique identifier? And what will that unique identifier look like?
So data is local and it's owned by the hospital and the county and the patient. So no private company can own your data. So the only thing we can do is enable that data use and maximize the value from it for the hospital's consumption and for the use of healthcare progress. So if your data is within those hospitals, and then we can access those hospitals and turn those paper records to digital record, it will be preserved. If your data is no longer in those hospitals, or your hospitals where you were born have transitioned into maybe bigger facilities, or they are no longer existent, then your data is lost. Oops. Unfortunately.
And most of them then is lost.
Yeah, the issue of EHR, electronic health record, and having that unique identifier and longitudinal traceability of your data record is still not even achieved with the US government. It's not been achieved anywhere. It's something that is still under debate, is still under construction, I would say. So right now, whatever we just want to achieve is visibility and representation, that the data in Africa is well captured and is available for use. That is something that is 85% not done across Africa. So we start there. And then after we do that, remember, 25% of the disease burden in the world comes from Africa.
25%?
Yes. Out of all diseases in the world,
yes,
a quarter of those diseases are from Africa. Or Africans are sick 25%.
These guys don't, they just cook up numbers somewhere and say Africa is suffering, the 25% is theirs. How are they arriving at that data, whereas they don't have proper data collection systems?
That is WHO reports. You know, WHO now has penetrated our systems through vertical projectization of programs. Like Kenya EMR, let's say, which captures most HIV diseases, right? Has been sponsored vertically by USAID. SPICE has been sponsored, which captures diabetes and hypertension diseases. So there are systems deployed. That's why I said it's fragmented. In several pockets and heat maps of Africa where this data is captured and compared to the numbers from the global north.
So that 25% could be under reporting?
Highly likely. So of those ones that are captured and reported, right now the current data shows 25%. And remember, when it comes to clinical trials and data use, in Africa is between 2 to 3%. So global data use that is originating from Africa is only 2 to 3%. So, but we have the highest disease burden. So you can imagine if there's drug discovery, the representation of African genome or African data is 2 to 3%. So the problem is, how are decisions being made without representation from Africa? Because there's no enough data coming from Africa, and that's the problem that Afya Analytics has come to solve. So once we are able to have that data, then we'll be solving the right problem. We will know how to deploy resources based on evidence and solve the right problem. And for chronic diseases, which now in 2050, out of every 2 people, 1 will be suffering from a chronic disease. You can imagine how much.
I did read somewhere that 70% of people living today, 70% in the whole world, will die from one chronic illness or the other.
And maybe the other 30% will die from an infectious disease or an accident.
Now that's interesting. If 70% is going to die from a chronic disease or the other, my question again on this data question becomes, these very people who are providing healthcare services, are they properly trained in capturing of health data? One, are they properly trained on what to capture? Or do we even have a universal system that requires particular important sets of health data to be captured? That's one question. Number two becomes the question of the unique identifier. Because as I was just talking, I'm trying to remember, Faith. From when I was young, I remember going to different hospitals, but the best they would ask me, what's your name? And there are so many Brian or the Ambotinos in the world. So if, for example, I went to Hospital X in Nairobi when I was young, and 3 more Brian or the Ambotinos went there today, even in the wake of this technology that you guys are having at Afya Analytics and many other firms which could be doing whatever you're doing, how do we structure better the question of the unique identifier? Because we need one unique identifier where nobody else has it. Is it going to be biometric? Is it going to be a number? What is it going to be basically?
So I don't know if I want to answer your question or to dwell on that, because number one, unique identifiers are like your birth certificate number, your
Which
ID
I don't
number.
know. If you ask me my birth certificate number, I don't know.
That's up to you.
Do you know yours?
There's your ID number.
Do you know your birth certificate number?
Not top of mind, but I have it.
Of course, everybody has a birth certificate somewhere, but I can't recall. I mean, genuinely.
So yes,
Yeah.
the government is able to have a unique record of you.
How do they have that unique record of
But
me?
you know, healthcare records are very protected. The data protection is heavy in healthcare because you are entitled to your privacy.
Okay.
And even the kind of data anyone is allowed to access is anonymized. No one will ever know whose data it is. And it must be at scale where then it's used to make decisions for disease surveillance, for planning, for proper public health indicators, and not necessarily about you as an individual. About you as an individual, unless now you give consent that your data can be used. Maybe you're suffering from a rare disease or a disease that doesn't have a cure yet. Remember, any chronic disease does not have a cure yet.
Any chronic disease?
Any chronic disease.
Can you
There's no cure for arthritis.
Yeah, can you list for us like 10 chronic diseases?
Yes.
Yeah. Let's go. 1.
Diabetes. Kidney disease. Cancer. Arthritis. Sickle cell anemia. Schizophrenia. ADHD.
ADHD? Is it a condition?
It's a chronic disease.
Well, I know somebody has one.
Depression. Alcoholism.
Alcoholism is a chronic disease?
Yes.
Just drinking of alcohol?
You put it under addiction. You put it under mental health.
Okay.
But it's chronic. It doesn't have a cure. You can only go into rehab and have remission, but you're always at risk. That's why there are AA or Alcoholic Anonymous, where people go for support throughout. Because if you stop, you can relapse.
Okay.
Anything that can relapse is chronic.
Okay, 10.
Eczema.
Eczema.
Yeah.
Dry skin.
Yeah.
Okay,
The disease of the skin that makes you itch.
Let's continue. 11. Asthma
Yes, asthma.
is a chronic illness.
Asthma, and then obstructive okay, it's called OCPD.
OCPD.
Obstructive pulmonary chest disorder or something.
Okay, it has something to do with the chest.
Yeah.
That means you don't breathe properly, or what happens, basically?
You have to ask a chest physician.
Okay.
But I know it's a chronic disease.
Now let's
eye conditions.
Yeah.
Are chronic. Yeah.
Let's come.
HIV.
Yeah, actually, HIV is a chronic illness. We talked about diabetes, right?
Yeah.
Diabetes is chronic,
Yes.
and it attracts quite a number of stuff.
Obesity.
Now, obesity is.
Hypertension.
Yeah.
So we're already at 15.
So there's nothing
There are
like.
over 26. There's so many.
There's nothing like I am fat because this is how my family is.
Immediately you are in a place where there's nothing you can do about how big you are, and you keep getting big. In fact, there's so many studies going on about obesity. Remember, as life goes on and there's ultra-processed foods, there's an increased industrialization and increased urbanization. There are diseases that are that are inevitable. It's not that you're causing them upon yourself. Let me tell you an example. When you're born, you never asked your mom to give you sugar, did you?
No, but it's sweet.
But they were
I used to
sugar.
steal.
If they don't put sugar in your porridge, you're
Oh,
I told you will cry.
Yeah,
And ask for sugar.
you don't have to go personal. but I know my mom told you. I never loved uji. I still don't love it. But I'm told it's a healthy drink.
Let me say another example.
Yeah.
How many 4-year-olds, 3-year-olds do you see in a KFC having soda?
That is a concern. And those chicken which you don't know how it is properly made.
Or something that is deeply fried, right?
Yeah.
Those children have not asked for it. So already they are introducing their systems to ultra-processed foods or foods that are maybe highly fried under high temperatures or extreme sugars, like 50, 60, 70% sugar foods at the age of 3. How do you expect this child at the age of 30 not to take sugar or not to be fat? So then why are you telling them that they are fat and shaming them, asking them to go to the gym when you don't know that is food addiction, that's sugar addiction, and it's
food addiction,
yeah,
introduced at a younger age,
in dopamine induced. So already, in fact, even whether you're fat or not, if you're taking that much sugar, you're already predisposed to early chronic diseases.
So if
like osteoarthritis or early onset prediabetes, metabolic syndrome.
So if we did have proper data systems, we could be able to regulate some types of foods coming in, because they're high-risk foods. For example, soda. Should people take soda?
Not at all.
So soda is bad for the economy?
No. Yes, it is. Not for the economy, for your health.
But it's also bad for the economy then, because if you're unhealthy, the economy is unhealthy. Is that so?
So, of course, it has to be approached at a policy level. Because
free market. We live in a free market where everything goes. And
remember, soda
is very sweet.
Has multiple risks, because number one, it's ultra processed, it's preserved, so under so many chemicals. And number two, that's number two. Number three, it has a lot of sugar. So already, and then number four, it's in a lot of plastics. So you're being introduced to microplastics, a lot of things your body doesn't need. Then your body is working hard over time to just detox and get rid of these sodas that you are taking compulsively. So chronic disease.
So soda is not food?
Not at all. I don't think it adds any value to your system. I don't think soda has any nutritional value. Soda has zero nutritional value.
How many bottles of soda should you take in a week?
None.
In a month?
None.
Okay, in 2 months?
If you're thirsty,
not even
take
one?
Water.
In 2 months, one?
If you're thirsty, take water.
Well, they advertise it so nicely. If you're thirsty, take. It's very nice. And they even gulp, quat.
So then you see, by design, we are meant to fail.
So it is induced consumption.
Yes.
Are you saying in a year nobody should take soda even once?
In a lifetime.
In a lifetime?
Nobody should take soda.
Okay, what is the ingredient that is used to make soda?
I don't know. I don't work for...
You've never tried to investigate as a medical...
But so long as something is sweet in your mouth...
It is wrong.
It has sugar.
Okay.
Even things that are not sweet, like ugali rice and, chapati, we all know they have sugar. But the sugar you should be looking towards is the complex sugars, the natural, anything that looks like how it was on the farm.
Like I like eating granola. Is that safe?
Whatever...
A mix of pumpkin seeds and oat and whatever.
I don't know the processing aspect of granola, if it makes it safe. The processing aspect. And then also high consumption of oats. There are studies going on. I know there are epinutrients in the oats, like fibers. But there are also the way it's processed, the way it's packaged, the way it's preserved for longevity, that introduces risk and maybe toxins. So
you're saying soda is wrong. This just keep with us. This is just on the part of finding this data, and we must go to the examples of what health data means, because
now that is consumer data.
There's consumer data, that
is health adjacent.
Yes, because when you take soda, you're saying nobody should ever take soda ever in their lives. I've been taking so much of it. I don't know if I'm exposed already. Am I? Do I look like I'm exposed?
If you depend on taking soda, or you say I'm...
Well, I take it once in a while.
That's fine. You'll burn it probably by walking or running.
Okay, so if you take soda, you need to burn it.
Yeah, but I would discourage just too much consumption, because then it introduces so many toxins to your body. And unless you're doing so much to counter the toxins effects, that's how cancers. Okay, there's no particular research needs to be strengthened and expanded
around
to
cancer,
understand even the causes, because these things are possible. You remember how rapid research was during COVID, and there was a vaccine. So if everything had that much zeroing and attention, we would be having so much progress. But in Africa, we don't even stand a chance because we don't have that visibility. Remember when Lupita started talking about fibroids, and there are certain growths that are predominantly affect women with melanin, like polycystic ovarian syndrome. Nowadays it's been renamed to polycystic metabolic ovarian syndrome. Right. And so many other cysts that affect women, the keloids. There's no one who's bothered about it because it's predominantly in the Black community in Africa. And we are not harnessing enough data and harvesting enough data that then brings visibility to this disease as a concern. Hey, women in Africa have fibroids. Well, there's so many, like out of 10, 8 will highly likely have fibroids. Yeah, so data can really inform or direct you on the critical concerns in the healthcare system.
So I have 2 more questions still on this subject. I said you keep with us because soda has been knocked off. That soda is wrong. So then there's the question of fried chicken I'm talking about. I don't want to name a particular company. But of course we know, and you know, and I know, and everybody else knows about this fried chicken. I also think that fried chicken is wrong.
Yes.
So I should never eat fried chicken.
Yeah.
Especially that is honey glazed. Have you? Honey glazed fried chicken.
That even makes it worse.
Honey glazed fried chicken is too sweet.
Yes, glycation. Sweet is neither here or there. Let me tell you. But a pawpaw is sweet.
Pawpaw isn't sweet.
Pawpaw is sweet. A dragon fruit is sweet. It's sweet, it's colorful, it's orange.
But it's raw.
Yeah, but it's sweet in the mouth. It's sweeter than chicken, if you ask me. But why do we think chicken is better?
Honey glazed chicken.
Because of social engineering.
Yeah. Honey glazed chicken is very sweet.
It even makes it, the fact that you even add sugar on the chicken makes it even worse.
So you should not eat honey glazed chicken.
Remember, this chicken in itself predisposes you to antimicrobial resistance.
How so?
Because these chickens, these broiler chickens that are mass manufactured at scale, and they are under lab conditions where they are immunized, they are given antibiotics, they are given mash chicken feed, they are given, like, the process of manufacturing them, transporting them, storing them is not even maybe at a small scale, but it's not preserved, it's not carefully monitored for the safety of the human consumption.
Chicken is manufactured.
Yes. I'm sorry, it's naturally occurring, but it's manufactured.
Are you guys getting this? Chicken is manufactured. Chicken does not just grow.
These pink chickens are manufactured.
Pink chicken. We even have pink chicken.
Broilers.
Oh God. So where do we go?
just
everything seems.
So I can tell you.
Everything seems to be working against us.
The possibility of you just farming chicken and let it be grass fed and organically fed.
Like it just works like the normal ones.
Chameleons and
they eat chameleons.
Okay, maybe lizard. I don't know. But those are
okay. Some of them eat defecation. I've seen that. Is that proper? Should you eat chicken?
Chicken that grows over a year, 2 years.
Okay.
That's the chicken you should be.
So you should not be eating manufactured chicken within 6 months.
3 months, 6 months, you're eating a spring chicken already.
Because you're talking about. I remember when we visited that conference where they were doing the AMR thing, antimicrobial resistance, and something that also stood out for me was because our audience has not yet quite understood how consuming hen chicken, pink one, can lead to you developing antimicrobial resistance. So maybe, can you put it further in further context? What is antimicrobial resistance?
Is when, have you heard, like even the biggest mortalities, like maybe mortality data needs to be studied, but most mortalities are from sepsis.
Sepsis?
Yes.
Sepsis is like wound?
Yeah, sepsis is when you have an infection that cannot heal.
Okay.
So these infections are caused by you being resistant to medication. Like the infection has exceeded the available interventions.
Okay.
Right?
Okay.
Then you die because you cannot be treated. So that's same to antimicrobial resistance. When you have an infection that is beyond the strain of the levels of antibiotics available to counter the infection.
So whenever you have an infection,
Yeah.
whatever is always prescribed
It's an
is
antibiotic.
antibiotics. So when you eat chicken, it's like you are consuming antibiotic, this pink chicken.
Because you do not know which grade of vaccines or antibiotics, because chickens get sick and they can die. Like I've met so many chicken farmers where they have 500 chickens, 600 chickens, 1,000 chickens. If one gets an infection, the whole batch dies.
So they have.
So to prevent this mass death
Yes.
and to preserve their stocks, they have to keep injecting them by design.
Yes, yes.
Yeah.
So that is preemptive. They do something preemptive vaccination, where they maybe not call it vaccination, but they call it vaccination anyway. Preemptive antibiotics issuance to chicken.
Yes. And
Even if the hen is not sick, they just give it antibiotics.
Yeah, so that it doesn't die, to increase longevity, so that it matures for our consumption. Right?
Oh God.
Food production is a whole thing. So by the time it's on your plate
Yeah.
and the antibiotics are still within it, maybe even the methods of handling it, the antibiotics are still you consume. You're also consuming those antibiotics, and you don't know.
So your body naturally receives as receptors for antibiotics, even if it is introduced proxy.
It's part of the nutrients of the food.
Oh, it comes as part of the
Same
nutrients
to
now.
pesticides and cropping.
Oh, cool.
Right?
Oh, cool.
Same to the scumas we have that have been sprayed pesticides.
Yes, yes.
I did a study with a German company where we realized that these scumas, these apples, these
scumas are kales in Kenya.
Tomatoes.
Yeah, and tomatoes, yeah.
When they come to your plate, if they were not properly washed or properly grown, and they were grown under monocropping.
Monocropping is?
Same crop in
okay.
Maybe not an eco farm, but in a greenhouse.
Okay.
And they have also to be supported to mature faster. So by the time they're on your plate, they come with all those chemicals to your plate. So that's why organic farming is also a whole other thing. So this chicken, once you consume it and the antibiotics are in your body and you don't know, when you get an infection or you get a flu or you get whatever, because antibiotics are broad spectrum.
Okay.
And then you go to hospital and you're given antibiotics. You are supposed to heal. But if they're already existing in your stomach because you've been consuming too much chicken, then you're not able to heal. Then they have to go to the next strain, like the next level, until they reach like meropenem, like they reach a higher
highest level of
there's
antibiotics.
There's amoxiclav, then there's cefuroxime, there's ceftriaxone. There are so many levels. So by the time then you have sepsis, you cannot even heal and recover because you are antimicrobial.
So let's just go back there, Alibi. You said that what percentage of people die from sepsis?
I have to confirm those numbers.
That would be interesting for us to confirm. And of course, we're going to put it alongside this down here. You will see it. You'll be seeing it shortly.
Out of surgery and don't recover. Sometimes it's because of sepsis. The surgery, the wound just didn't heal, and then the infection spread across the body.
So then the health system,
the infection spread into the blood.
Yeah. So then the health system that would be developed to capture data would also have a part of capturing the diet. Because
so that would be ideal.
Yeah, because it's important.
Adjacent health data,
yes.
The consumer health data. And,
yes.
And Dafy Analytics is doing all that. Just the whole ecosystem of data that then has a net effect into how to improve your health outcomes. The primary concern here, or the primary solution, is to improve your health outcomes so that you have a fighting chance when you get a chronic disease.
Okay.
Like, God forbid you be here and you're told, hey, you have early onset gallbladder cancer. You have hope.
Yes.
But the reason why in Africa they say a cancer diagnosis is a pre-death sentence is because the hope disappears because you cannot rely on the system. And if you cannot afford to go to India or to crowdfund, you just give up hope and you become discouraged because access and affordability are big barriers to healthcare. So at Chronic Disease Society, we really want to collect all these problems, understand them from the patient's perspective and the lived experience of people who've gone through this, and then harness and package them into policies that then improve the healthcare system.
As we go towards the end of this conversation, one of the most important questions that is coming up in my mind is the question of data storage in Africa. Of course, let's first deal with in just a minute, the ethical collection of data. We don't have proper ethical frameworks in Africa to collect our data. Is that so? Would you say that?
We do, like NACOSTI.
Yeah, what's NACOSTI?
Kenya National Science and Technology I have to find.
It's a regulatory body for data?
For researchers.
Okay, for researchers.
And for you to do certain healthcare researches, you need access to data that's not anonymized. We have
but that is
pseudonymized data.
That is study level data.
Yes.
But now how about what I call the continuous data collection on citizens? Continuous, just like the government captures, you bought XYZ, there's fuel that has come into the country and this is how it is selling. This is how it's retailing.
Ethical use of data.
So how, that's what I'm asking.
Ethical use of data is possible and it's being done.
Ethical collection.
Ethical data collection is also being done. But you are given these ethical mandates by bodies like NACOSTI, KEMRI, KNH, big referral and teaching hospitals. And you must qualify why you want to use this data, what study, what is the health outcome, which subjects or key populations are involved. So you must be able to be accountable, monitored, and evaluated.
Would you say that data collection on health questions should be compulsory at the point of interaction between the individual, that's the customers, and the systems, the health systems? Should it be compulsory so that we don't use it at study level alone? So we use it as continuous guidance that we are having continuous data coming in.
Exactly.
It should be compulsory, right?
Yes. That's what Afia Analytics does.
Okay.
However, now the use is controlled so that there's no misuse.
Yes.
Right?
Yes.
And abuse of
Yes.
this particular data.
Yes.
And there are regulatory bodies that make sure that this happens. And
Okay.
anyone who's in that space reports to another secondary or tertiary body that then makes sure that they can audit the processes and ensure that your data was ethically used.
So
that's not even in that's not an issue at all.
Ethical collection, which we have agreed should be compulsory anyway, but in an agreed manner, then we go to the storage of this data. Does Africa have the capacity to store their data?
Yes, there are data centers. Data warehousing
Yes.
mostly has, of course, elevated to cloud level with Amazon and Google and Microsoft. So there's AWS cloud hosting. But now when it comes to healthcare data, there are certain jurisdictions, and mostly the preferable way is local ownership. So the data warehousing must happen locally within the country. Rwanda has done it, Kenya has done it through Konza cities and data centers and many other data centers. So then that way also comes down to the government of the day, is the one to ensure that anyone who's locally operating any local data hosts it locally and warehouses it locally. And in any case, if then it transcends borders, the logistical and supply regulations are applied and guidelines. So all these things have been catered for. The underuse is because of the fear that I was telling you about, the fear of navigating the system or being compliant. But once someone is compliant, then they have the freedom to do that, and then they can probably use this data to improve healthcare outcomes. Data
collection, storage, utility is quite an interesting ecosystem. My question as we end is this: what do you think is the future of health data in Africa looking like, one? And two, how does Africa exist with its health data in the global health ecosystem? And lastly, how does this help us in developing our own African cultured solutions or African grown solutions instead of depending on external guidelines and directions?
Those are many questions.
Yeah.
It's loaded. However, I'll start here.
Yes.
There are talks and there are headways to ensure that local manufacturing comes to Africa. In Africa, 70% of the pharmaceutical medicines, drugs we consume are imported. They're not manufactured locally. And for the ones that are manufactured locally, predominantly manufactured in South Africa, Egypt, and North Africa, and North Sub-Saharan Africa. In Sub-Saharan Africa, the manufacturing capacity is quite low, maybe less than 15%. So the efforts to increase manufacturing capacity is to start harnessing and locally owning our data, because manufacturing of drugs is data-driven. Any medical agency, any regulatory, FDA, whatever, cannot make a decision about a drug without evidence, without data. So bringing the data home and localizing our data is what will enable our manufacturing capacity, right? So the Africa Medical Agency is trying to increase this effort to be able to have enough to even start clinical trials, because the process of manufacturing a drug starts with discovery and clinical trials, and then real-world evidence generation, pharmacovigilance, advanced incident reporting. All this cannot happen without data, without longitudinal linked real-world data. So for this to happen, Africa has to, first of all, own its data and use its data ethically, in a manner that can be audited, in a manner that is visible, not institutionalized, right? Then secondly, am I forgetting a question?
How do we then come with our data into the global space?
So we need to have, once we ensure the equity, then we will have the power to then represent our own stories.
Because right now it is people telling us about us.
Tell our own stories.
Yeah.
And to comply and partner and collaborate with solutions that then take us forward. No, not resisting the solutions, but participating and being part of the solutions. So you might find there are so many scientists in Africa, but our doctors, I dare you, even in the comment section, you can comment if you know, our doctors study medicine using Mayo Clinic data, using data from Europe and the US. African data is not used in our schools. African data is not well captured to even qualify for peer reviews and used in our schools. Doctors, you find mostly they go for their masters abroad, because in Africa there's no enough resourcing. Because masters is about data, it's about studies, it's about discovery. So why? Because the systems have been weak and porous and not enough to complete those journeys. We are here to change that. Actually, the conversation has moved forward. Now we are here to embrace the solutions. We are here to lean into our data and use our data. Yes.
Very good. There you have it. The question of health data in Africa is a concern. And of course, we've looked at the largest bits and the smallest bits of it. Of course, soda is bad. Fried chicken is bad. And most importantly, our data is very bad. From the collection to storage to utility is a concern. And most African nations have not yet smelt the coffee, that things are not the way they should be. And of course, we appreciate Faith Okwisa-Okwayo, who is the Director of Partnerships at Afya Analytics, for coming on board and sharing with us this question on health data. But also, most importantly, as the chairperson of the Chronic Diseases Society of Africa, helping us just to understand what the efforts of CDSA, which is the executive production team of this podcast, is trying to do to improve data collection. Something that has shocked me is that my data when I was born and my data where I am now is not available. And that private hospital that I used to go to in Kisumu, Kenya, closed. And so that data is lost. And this is the case of very many other Africans. So of course, we continue this conversation online, and always keep it here at Africa Health Pulse, where we do discuss the pulse of Africa's health. We try to understand what is happening with our situation and how can we develop homegrown solutions to the African question. Because right now, we are looking west, but it's time to look back home. This has been your favorite health podcast, and with me, your host, Odhiambo Brian Otieno, the CEO of the Chronic Disease Society of Africa. Keep it here, and don't forget to subscribe and put or push that bell so that whenever we bring up a discussion such as this one that is most important in elevating your knowledge around health, you never miss a session. Till next time, enjoy.